Welcome back to What the Fertility Season 4. Today we have a very special guest, Dr. Mickey Coffler, who is a board-certified reproductive endocrinologist and infertility specialist at HRC Fertility located in Southern California. Dr. Koffler's clinical interests include infertility, recurrent pregnancy loss, egg freezing, PCOS, gender selection, and more. We are so excited to have you on the show. I know we did a Q&A earlier in the week, and listeners are very excited to learn more about you and have an expert on the show. So welcome.
Thank you. Thank you so much for having me, Catherine.
Absolutely. So let's start, I guess, where your career started. I see you studied in Israel, both for your undergrad grad and a little bit of your residency. So do you want to start there?
Absolutely. So, yeah, I completed my medical school at the Israel Institute of Technology in Haifa in Israel, and then I moved on and actually completed a residency, an OBGYN residency there before moving to the US for a actually, it was a subspecialty training. I pursued a subspecialty training in infertility, in reproductive endocrinology. And later, kind of life, guided me or took me, and I decided that I will stay in San Diego. And I then moved to Cleveland to complete a local and OBGYN residency here in the US. And that's kind of how I ended back in San Diego, being a subspecialist, like an REI specialist, and joined HRC Fertility upon basically completion my REI fellowship at the UCSD.
That's
So it's a
awesome.
long, it's
Yeah,
a long course.
that's a career. I know.
Yeah,
Yeah,
I'm
just
super trained.
yeah. I mean, I can't blame you for wanting to stay in San Diego. I think anybody anybody would want to live in that area.
Yeah, it's really beautiful. Although today it's kind of raining here, but it's still no complaints.
Absolutely. And your HRC fertility, beautiful for facilities. And I know you have a couple practices down there, but I guess like the biggest question is OBGYN, that's a lot of training in itself. And so what was your passion or what interest led you really to say, hey, I think I want to move into reproductive endocrinology? Because there's a big gap from your OBGYN training to REI training.
Yeah, so that was actually that was fascinating. I mean, the I was always attracted to human reproduction. Actually, during my entire medical school, I took every single elective that I could put my hands on that was related to, to reproductive hormones, human reproduction, anything. And actually, we were quite lucky that we had a bunch of electives that I could really participate in. And then that led me naturally to the OBGYN specialty. But then one day when I was doing my IVF rotation during we had actually a very active IVF practice in Haifa where I did my training, and and during my IVF rotation I had one of my attendings, which was really, I mean, we had some very awesome, very talented reproductive endocrinologists. One of them showed me under the microscope. He showed me there was the first phases of pre-implantation genetic testing. It was when actually chromosome were still evaluated with colors. I mean, we had markers. There were markers. It was called FISH, uh,
Yeah, yeah.
fluorescent in situ hybridization. So basically, each chromosome was assigned kind of a color, and you could see them under the microscope. And so basically, you take some cells from the embryo, you paint those cells with those markers, and then you can identify the chromosomes within the cell. So you can identify, which embryo has a normal number of chromosomes, which doesn't. That kind of was, for me, was fascinating. I mean, I felt that, okay, wow, this is science fiction. I mean, this is exactly where I want to be. And that's kind of led me to the to the next phase, to do the to apply here to fellowships in the
Yeah.
US, and I was lucky to be accepted at the UCSD.
That's amazing.
So that's kind of my story about infertility.
I think that's so amazing. I work with OBGYNs for a living, and I don't think that's a lot of schools here in the US in that residency program give them that IVF like opportunity, or if the rotation is there, it's very quick. So that's so amazing to hear that that was your experience. And really my next question was going to be like, what is your most rewarding aspect of your work currently? And it sounds like obviously you have some specialties in like the chromosome field and donor embryos and recurrent pregnancy loss, but has that kind of evolved from residency to now? Is there any big topic or big area of reproductive endocrinology that you really get a lot of reward out of?
Well, I honestly, many people think that, and myself, I obviously, this is the first thing I mentioned. I mentioned that pre-implantation genetic testing really changed my career path. But really, I feel that in IVF, first, IVF itself is revolutionary. I mean, it really changed lives of people and opened so many options for people that were hopeless in the past, to actually start and have their biological children. But I think the biggest again, it's my opinion that the biggest step that happened in IVF and that was like a second revolution was actually the ICSI, the intracytoplasmic sperm injection, because till then, really, even with IVF, success rates for male partners with either no sperm or in the ejaculate, right? So either no sperm or very low sperm counts were still almost zero.
Right.
But with this invention of intracytoplasmic sperm injection, you can actually extract, even one single sperm cell for the testicles and give that couple a hope for a biological child. And this, I think, made really a big step because it almost, I would say, eliminated the male factor infertility. So
Yeah, well, I'm
practically.
so glad you brought that up because I've done one round of IVF and we'll kind of go back and forth on what my personal experience is, but that was something that we opted to do, and I know it's still kind of I think a lot of fertility clinics have adopted ICSI as like this is just like our standard, but for the listeners, you did a really good job explaining it. But really, I think just for listeners that haven't done IVF before, you're saying that with ICSI, I mean, you get to pick the best sperm. So if a male has like poor sperm sample for whatever reason that is, you guys now can pick the best of the worst or the best of the best and directly implant it with the egg. Is that correct?
Correct. So, it's done under a microscope, and it requires skills. It definitely requires big skills. I mean, if you don't have the right skills, if you don't have the right embryologist, you can actually damage the egg during that process. So it does require a lot of skills, but there are great people that do that. So by now, it became quite routine. But to your question, yes. So the way you do it, you identify under the microscope sperm cells which have the normal shape. I mean, we don't have really at this point more functional tests to really characterize the sperm, but we can at least look at the shape, and the shape probably correlates quite well with functionality, and therefore it allows, like you said, to choose the best looking sperm, inject it directly into the egg, and hopefully result in a healthy baby
That's
at the
awesome.
end, and really with one sperm cell, which is really it's fascinating.
Yeah, yeah. And so before then, like you said, I mean, we were just everybody was just hoping that the right sperm got into the egg. So yeah, I love that answer. That's awesome. I think I saw that you like and specialize in some male factor infertility. Do you have any experience since we're talking about sperm? Do you have any experience with like DNA sperm fragmentation? I know that's like kind of iffy these days, and it might be more, I don't think it's as mainstream. Do you dabble in that field at all?
Yes. So again, you're absolutely right. There is still, um, I would say that the evidence is not very hard regarding the sperm DNA fragmentation, but I think the research is still ongoing. So I wouldn't say that you know, it's something that shouldn't be considered. I think it should be considered, and definitely. In cases that we don't have any other explanation for failures, I think it's definitely something that should be looked at. I don't think it's something that should be looked at routinely because, like I said, there is not enough evidence to suggest that every patient should have sperm DNA fragmentation.
Right, spot on. That
And
was my example. And so kind of moving into some of the listeners' questions, and I'll be selfish and I'll put the reoccurrent pregnancy loss at the top. So
yeah,
I've had eight miscarriages, and out of those eight, I still have no answer. And so to your point, like you just said, we were kind of at the end of the road after the seventh loss. We were like, let's look into DNA sperm fragmentation. But one of our listeners had asked kind of what is your approach, if any, with couples that are kind of facing reoccurrent pregnancy loss? And could you also, before we jump into that, just define what reoccurrent pregnancy loss is for listeners?
so the formal definition is essentially two or more consecutive clinical pregnancy losses. Clinical usually means that there is a well, ultrasound evidence, for example, of a pregnancy. So that's kind of a broad definition, and the workup, starts always with the history taking and studying of doing the physical exam and then imaging. So we look basically at um, medical background, if there are any suggestion of hormonal imbalances. We look at prolactin, uncontrolled diabetes may contribute to it. So those are really general things. Those are really not very common though. So then on imaging, we look for anatomical problems. Uterine septa were quoted as possible contributors to miscarriages, and they can be potentially corrected. So we look at that. We look at that by either ultrasound and sometimes we need to use hysteroscopy, which is direct visualization of the uterine cavity. In the um, more more sophisticated testing, basically we do a semen analysis, although I don't think that the semen analysis has a major contribution given that the patient gets pregnant. So in those cases, I do order the sperm DNA fragmentation as a complementary test, just to make sure again that there is nothing that may remotely, that may explain the cause for pregnancy loss. So overall, unfortunately, after most of the time, I would say, actually, although in the literature it's about 50%, most of the time we don't find a cause. Now, I forgot to mention we do genetic testing. That's what I meant in a more sophisticated. We test the patients for chromosomal rearrangement. It's
Yeah.
not necessarily chromosomal abnormalities, but chromosomal rearrangements. And those are really also quite rare. So altogether, after we do kind of a major workup, including hormonal, anatomical, genetic, imaging, most of the times, I would say, we really don't find a cause.
That is just,
So
you're speaking my language. I've gone through this for 5 years. I do have a 2-year-old daughter, and I'm 20 weeks pregnant right now. So I'm sure you're probably shaking your head like, yep, it just sometimes it'll work itself out. But that is really interesting for me to hear you say that, sometimes, half the time, we still don't find reasons for this recurrent pregnancy loss after the workups.
yeah, and that's the truth. And at the end, we know that um, many of the miscarriages, and in some studies, it's quoted as 60, sometimes even 70% of miscarriages are related to chromosomal abnormalities in the embryo. Um, and and I understand that, for example, in your specific case, that was not the case. I mean,
I was
most of
gonna
the
say I didn't want to
and
ask because it's you're not a like genie that you can just tell what
yeah.
happened. But yeah, in my case, we tested almost all of the embryos, and I think they were normal through the testing, right? Well, and the testing can only tell you so much. I understand that. And then maybe a question you could answer is I did do one round of IVF, and we did have the embryo PGT tested. And so maybe we can explore what different types of PGT testing there are and what they can and cannot catch, because that one did end up in another miscarriage. And so it's like it comes back genetically normal, but PGT testing can only test so much. Is that correct?
So you're right. So PGT testing can, number one, it will identify generally if an embryo has the correct number of chromosomes. So we inherit a chromosome, a copy of a chromosome from our mom and one from our dad. So totally we have 23 pairs of chromosomes. And pairs, that means that it can't be more or less. It has to be a pair. So any extra number or missing the number of chromosomes that results in an abnormal embryo. So that's number one. We can test the correct number. The second is that we can look at the level of the gene if there are any single gene disorders, and that's called pre-implantation genetic testing for monogenic disorders, in a professional term. That's not necessarily relevant to repeat pregnancy loss, but what is relevant is we can test for rearrangements. And during the creation of the sperm and the egg, the chromosomes are kind of sorted, or they have to separate first of all. During the creation of an egg, the chromosome have to separate correctly. So what happens if there are rearrangement within those chromosomes, like a piece of one chromosome gets attached to the other accidentally, then when those cells are separating, okay, those chromosomes are separating, then one daughter cell can have a missing piece of chromosome, and then the other daughter cell can have an extra piece of chromosome. So that's causing what we call unbalanced number of chromosomes in those cells. So if for example, one of these sperms, which maybe was one of the questions that came up, if one of these sperms is going to fertilize an egg, so the sperm already has an unbalanced number of chromosomes, then it will result in a chromosomally unbalanced embryo. So with this technology, with pre-implantation genetic testing, you can identify those embryos and obviously avoid transferring them, because if this happens and there is a birth of a child, or there is a pregnancy resulting from a unbalanced sperm fertilizing the egg, or then an unbalanced chromosomal embryo, it may result in a miscarriage, or it may result in a birth of a child with birth defects or developmental disorders. So basically, this technology allows us to identify those embryos prior to transferring them into the uterus, which is, again, it's a huge advancement that we made during the last
Absolutely. And that was my
years.
whole entire reason for me going into IVF. I'm like, maybe we can test the embryos and make sure that, there's not a balanced translocation or a balanced rearrangement. I know those can be a little different, but thank you for describing that. I think there was a previous episode where I tried to describe it and it was not that clear. So I appreciate that. I think kind of moving through just the last one or two questions for recurrent pregnancy loss. My story. I never did go into like the full reproductive immunology space. That's not something that I went into, but I did feel that I found success with Lovenox, which I know can we in that original workup that you had mentioned, that I think one of the first tests you guys do is just like the blood clotting disorder on the women. And so for me, all of those came back negative, the lupus, anticoagulant, the APS, the factor five. I may be saying some of those wrong, but I actually was tested when I was not pregnant and when I was pregnant, and they were all negative. But for me, my current successful pregnancy and then my pregnancy with my daughter, I did Lovenox. And I don't know, do you see that working as like a kitchen sink approach in your clinic, or is that something that you haven't seen so much?
So first of all, the immunological system, I guess it must have a role in establishing a pregnancy because the pregnancy itself is a foreign body, right?
Right.
So if you conceive you yourself, you conceive with your husband, right? So at least half of your embryo or half of the genetic material in your embryo is foreign to you. When we transfer an embryo to a surrogate, the entire embryo is foreign to the surrogate. So it's not. It's basically there has to be a role of the immune system in uh, avoiding the rejection of this embryo as a foreign object, as a foreign, uh, basically body
Yeah,
to your
absolutely.
innate.
Yeah.
So um, we have some ideas how this works, and it may be that during and some women that have repeat pregnancy loss may have an dysregulation of the immune system, which may lead to wrongful rejection of an embryo. Uh, Unfortunately, I have to say, there is a lot of studies, there is a lot of research in this area, and we are still not understanding fully how all this works. But unfortunately, at this point, we don't have really good tests and very specific tests to identify a dysregulation of the immune system that may explain those
Right.
type of outcomes. And therefore, when we talk about treatments like Lovenox, anticoagulation specifically, those are kind of broad treatments that are made on the assumption that, for example, in this type of lupus anticoagulant, or so those type of autoimmune conditions, they activate the coagulation system, and by doing that, they basically uh, maybe block the blood supply or destroy the blood supply to a pregnancy and as a result of that causing a miscarriage. So those are kind of blanket treatments. They're not
Oh,
really specific
yeah.
to anything. So if I use them, yes, I do use them, and I do see that some patients are successful after taking those treatments. To tell you honestly that this is the result of the treatment or this is despite of the treatment, I cannot be
I
very
my
honestly say.
REI who has been with me, both of mine were spontaneous pregnancies, but he has really been at my in my corner, and he too says, I'll give you the Lovenox, but I don't think that's what's doing it. So I totally understand. So there's a couple more questions. There's actually a handful more. Would you prefer to jump into some topics on endometriosis? We had a handful of those, or diminished ovarian reserve. Which one would you prefer?
I'm okay with diminished ovarian reserve. I mean, I can talk about anything, but
Yeah.
let's go
D
for that.
Diminished ovarian reserve. So Amanda is my co-host. She could not be on today, but she was diagnosed with DOR, diminished
Yeah.
ovarian reserve, at just, I want to say she was 24, 25 years old. Her and her husband did 3 rounds of IVF, and every single embryo that came back was genetically abnormal. So they moved forward with adopting embryos. So I think if listeners are listening, what kind of advice or treatment options would you provide somebody that I mean, they could be 40 or they could be 25, but kind of come in and they're immediately diagnosed with diminished ovarian reserve?
Um, so, Catherine, there is a big difference, and I think that's one of the main things that diminished ovarian reserve is not. Yes, it is a diagnosis, but the consequences in younger age and older age are totally different. When we talk about women that are in their 40s with diminished ovarian reserve, it's kind of a natural decline, and there are two things that we have to consider. When we talk about uh, treatments and success rates, it's egg quantity and egg quality, and both of them decline significantly with age,
Hmm.
but they don't necessarily decline in a related. They don't necessarily decline. They're not necessarily related one to each other. So um, yes, both decline with age, but it's not necessarily at the same pace. So if someone, for example, in their 20s, has diminished, is diagnosed with a decreased quantity, which will qualify her for the diagnosis of diminished ovarian reserve, it doesn't mean that the egg quality is diminished at the same rate or even comparably to the quantity. So in a young person, the egg quality, although, and I like this topic because I had multiple patients with this kind of situation, and I can tell you honestly that they were successful because I'm talking about, again, more the younger age
Right.
population, because their egg quality is still good. So I remember when we were when I was much younger, and the uh, when IVF was more in uh, in their beginnings, uh, we used to cancel patients right and left. I mean, when I'm talking cancel patients, like we would use to say, okay, you have only one egg or two eggs or two follicles. Let's stop the cycle and do it again. Or patients wouldn't, like, practices wouldn't allow patients to have an egg retrieval if they had one follicle. And
Right.
over the years, I know I I can tell you that from almost from the start of my practice, I felt that, we should give the patient a chance. And the success rates are not, well, yeah, it hurts someone's success rates if you have one egg and it fails. But at the same time, if you don't give the patient a chance and push the patient, for example, to a solution like egg donation, which is, it's very likely to work. Uh, I feel like you don't do justice for, I don't know if it's the right term to use, but I don't necessarily feel like you give the again you do the best for the patient. And over the years, I noticed that, particularly again in the younger population, even with diminished ovarian reserve, which sometimes can be quite striking, there are still many women that will get pregnant with their own eggs, even if they have one egg. And I
Mhm.
keep telling patients, what do you need for a baby? You need one good egg and one good sperm. I mean, this is really what you
Yeah.
need. And I this is so talking about one of the you asked me at the beginning. I don't know if I answered the more rewarding aspects of my career, where I had a I still vividly remember I had a patient that the husband had hardly any sperm cell. I mean, I can literally say we created two embryos from two sperm cells and two eggs, and
Wow.
one of them worked.
That
Actually, one of them didn't work the first time. I think she ended with a chemical pregnancy, and the second one worked. And I feel that if I wouldn't have given a chance to this patient, and before she came to see me, I think she completed 3 or IVF cycles at other places, and she was told, okay, you need egg donation, which again is not unreasonable, but
it's
maybe I
still
was lucky. But
possible.
I
Yeah.
was, I did encourage her, and it worked. And again, that's really all you need. And in young patients, I think um, I don't feel that a young patient, like it was my daughter. By the way, I have 4 girls.
Oh,
Uh,
wow.
so I would not discard. I mean, I would fight for it. I would
Yeah.
definitely fight for it.
I love that. I love that. And I heard you allude to it in when you were kind of explaining just your practice and how you feel comfortable moving forward with patients now with one follicle or a couple eggs. And I think that's such an important question for first time couples or women going into a clinic, of just really understanding what kind of clinics allow, and success rates. I heard you mention it can really limit patients and couples options at a clinic. So I just love that you're for the patient, you're for the couple, and you're really looking out for their best interest. I could not thank you enough for answering all of these questions for our listeners. I think the only other question we did not touch on, and we'll wrap up here, are what are some treatment options that you see used in reproductive endocrinology, or you personally use in your field, for women with failed implantation or reoccurrent failed implantation with IVF.
Yeah, yeah, that's a very stressful and heartbreaking, and I can't I can't use enough terms to describe it. It's very frustrating. So basically, when a patient fails, there is, again, we use a we try to make sure that the workup is complete. typically, I don't want to review all the workup because really most physicians are good physicians, and I'm sure that they cover everything. It's not that people are not covering, and I have to go back to basics like, oh, did you check thyroid? Did you check? Did you do a hysteroscopy? Did you? I mean, I believe that most people do that, and I think that it's not really that there is some omission on. Most of the time, there are no omissions. Most of the time, like I said, workup is completed. So you're really left with mostly unexplained situations. Now, we need to keep in mind that first of all, there are still, I guess, there are still many clinics that don't use pre-implantation genetic testing for their embryos. And if you don't do that, I feel that you may miss those situations where you transfer unknowingly chromosomally abnormal embryos, and they may look beautiful. I mean, they may look gorgeous. I can show you and listeners and patients. I have in my office basically an example of a pre-implantation genetic testing report with embryos grading next to it, and you can see that many of those embryos that look gorgeous, they are chromosomally abnormal. So when you transfer chromosomally abnormal embryos, I mean, what are you going to get? You're going to get nothing.
That
Uh,
is the
or
best
or
point. That
worse,
is,
you're going to.
yeah, I love that you made that point because then it looks like, oh, it's reoccurrent implantation failure. But in reality, that baby, whether IVF or spontaneously, that wasn't going to grow regardless. And that's kind of what happened to Amanda. She is so thankful she did the PGT testing because I think she had 5 embryos. And she said, I could still be here 2 years later transferring all 5, and they were never going to work. They were all abnormal.
Absolutely, absolutely, and that happens more than you think. I mean, again, if we as a practice, and I specifically in my practice, I almost insist to, I'm trying to convince patients that it is a legitimate test. I mean, nothing is 100%. I don't want to suggest that pre-implantation genetic testing can identify everything, and unfortunately, it may also be prone to mistakes. I mean, that means that maybe we are misidentifying embryos as normal or abnormal, and that can really. But I think overall, if you use a very reliable lab, I think overall it's quite accurate, and at least if you transfer a chromosomally normal embryo, again that you give the patient the best chance, and that's where
Absolutely.
the highest likelihood it is to be successful. Even then, you it's not that a chromosomally normal embryo is going to be a baby. Even then, the live birth rate can be 60%, 70% in some cases. I mean, maybe other clinics may claim higher rates, but it's not 100% either.
Right. I mean,
If
going
you
through this
transfer a
myself,
chromosomally
yeah.
abnormal embryo, it's zero.
Yeah,
I mean, it's going to
exactly.
be zero.
Exactly. Exactly. And I mean, I think infertility patients, recurrent loss patients, and professionals in your career, they just realize like conception and having a full term, baby, that's just such a miracle in itself. And we can throw all this stuff at it, but for that to work, I mean, there has to be so much that goes right at exactly the right time. And I really appreciate you bringing those topics up.
I think on my end, what I think is most important for young women now in this generation, particularly with the fact that women tend to do get pregnant later in their life. I think that the next revolution, and I think you have to look at it as really as preventive medicine, is fertility preservation. I
Absolutely.
think that's really something that maybe it's for a different podcast, but it is something that needs to be addressed. I don't want to say aggressively, but I think it needs to be addressed quite early. I think there needs to be education about it. I think young girls need to be kind of educated and at least informed about the fact that fertility is not granted and it's
Forever.
not
Yeah.
forever, and
Yeah. Would
Uh,
you, I actually, this would be really good just for a quick question on egg freezing or egg preservation. So I now am 34, so a lot of my friends are in this age. To your point, I mean, people are getting pregnant when they're in their 30s, a lot more than we used to see. And I have so many friends that are between 34 and 38 years old that are, I'm probably a big pusher of that. I'm like, just go get your AMH, just go kind of get an ultrasound, just kind of go check it out. And the results come back fine, quote unquote, if for listeners that can't see me. But what age would you suggest that women kind of really start looking at that if they don't have a partner, if they're in a position in their life where they're like, I'm really not interested in having children until much later. Is there an age or is there something that you would say, hey, why don't you at least go make that first appointment?
so again, I wish there was a straight answer. I can tell you, like again, I have four daughters, right? So my oldest one, she's a physician. She's 31, and she's not in a like she's not in a relationship that she feels like it's going to be long term. And she chose to freeze her eggs. So at the age of 31, she did 2 rounds of egg freezing, and I highly encourage her, and I'm going to encourage my younger girls.
Yeah,
If
I love
they
that because
if
you
they
can never. That's what I try to tell my best friend who said, I'll wait 2 more years. I'll wait 3 more years. And I'm like, you can, but those eggs are not going to be as good in 3 years as they are today. Like, just do it.
So going back to that, you're right. And if you remember what I said, about the egg quality and quantity, age, even if the egg quantity is lower, I mean, definitely if it's lower, I would freeze the eggs at a younger age. But even if it's higher, again, keep in mind the quality and quantity are not, yes, they decline with age, but they are not necessarily. So what I'm trying to say that even if you have a great number of eggs, it doesn't mean that their quality is perfect
Right,
and
right,
vice versa.
right.
So I generally, like I advise my daughter, my own girl, it's the younger you are, the better. And I understand there is a financial barrier. There are many barriers there. I mean, when you are young and in your 20s, I mean, it would be ideal to freeze your eggs, but you don't always have the money to do that. I mean, it's not free. It's not,
Right.
unfortunately, it's still quite expensive. I believe it's going to get better with time, and maybe insurance will cover more. In many other states, will step in and cover that. But I think the younger you can afford doing that, overall, you are more likely to be successful if you need to use those eggs in the future. It's not necessarily, I mean, obviously, not everybody's going to use the eggs. Maybe the minority will, but if you do, you
You
will
have them
not
as a,
regret that
yes.
you froze them younger because you can't go back in time. I mean,
Absolutely. Thank you so much for touching on that. So, for listeners that want to find Dr. Coffler, he has a wonderful Instagram, both at Mickey Coffler MD, as well as your practice Instagram, which is at HRC Fertility SD. And then your website, I believe, for the clinic is www.havingbabies.com. Are all three of those correct? And I will put them in the show notes.
thank you so much. Thank you so much for
Absolutely.
having me. It was a pleasure
Thank
talking to you.
you. It was a pleasure. Thank you so much.